1 and 2 malignancies are usually the patients who are undertaken for sentinel lymph node imaging and biopsy. So the patient has to be subjected for MRI and FDG PET-CT to conclusively rule out that there is no occult para-aortic or pelvic lymph node metastasis. The society recommendations like PIGO and NCCN guidelines state that lymph node metastasis is the most important predictor for early malignancy prognosis. So usually the sentinel lymph node imaging is undertaken in early stages of cervical cancers, that is stage 1 and 2. And we should concentrate during the imaging on the obturator, external iliac, para-aortic, and presacral lymph nodes to see if it is involved or not during this PET-CT imaging. So we need to also understand that patients who have been subjected to prior surgeries like lymphadenectomy can have disruptions of the lymphatic channels. Patients who are already known to have parametrial or nodal invasion by other imaging modalities, and those patients who have undergone pelvic irradiation, sentinel lymph node imaging may be going wrong because of the disruption of the lymphatic channels. Similarly, we should also understand that patients who have undergone bone biopsy or previous chemo, they are not contraindicated for sentinel lymph node mapping. You can very well go ahead by slightly tweaking the injection procedures. So let's understand what are the advantages of sentinel lymph node imaging with regards to cervical cancers. We know that FDG PET and other imaging modalities pick up metastatic nodes when there is at least 10 to the power 6 cells. So sentinel lymph node is much superior to FDG PET and other imaging because it clearly shows us presence of micrometastasis, that is, even to the tune of 0.2 millimeters can be picked up. So definitely superior. Also, in those patients, young girls who have still not planned for family, the sentinel lymph node has got definitely a high role to play because these are girls who can undergo fertility sparing surgeries. So if the sentinel lymph node biopsy is negative, so the surgeons can plan the patients in such a way that they can still go ahead and plan their family. So that is put in 2 trials which are ongoing and are quite favorable. The Centix trial is supposed to come out with the results this December. So we are going to see a recommendation from these trials that sentinel lymph node imaging can definitely take off in patients with gynae malignancies. So as we have already discussed the head and neck sentinels, even gynae malignancies, patients who are having visible tumors or palpable tumors, the injections are usually very tumoral. You need to evaluate the patients to understand how many injections you need to give. If the tumor is very small, please try to limit the injections to 1 or 2. You definitely may need the help of the gynecologist because the positioning, using of the instrumentations, we are not good at it. So we need to give a proper injection so that we identify the sentinel lymph node in an accurate way. So you can use either the technetium nanocolloid or the sulfur colloid. And unlike the head and neck sentinel, dynamic imaging has got no role. So you can inject the patient in the labor room, shift the patient to your gamma cannula room, maybe within 15 to 20 minutes, keep things ready, do a static imaging, and then go ahead by doing a SPECT-CT. But you need to understand where is the tumor. You may need to use a larger needle, let's say a spinal needle, because reaching of the tumor may be difficult when you use a normal needle. So these small things need to be discussed with the gynecologist prior to undertaking the any patient for the sentinel lymph node imaging. If the conization has been performed, we like to inject along the cicatrical scar area. So you can just limit the injections to 1 or 2. Care also should be taken that the cervical injection, especially in situ injections, we can give it at 3, 6, 9, 12. So because the cervical mucus will be very slippery, So they should be holding the lip properly and injecting it right in the place and not going deep into the cavity, because inadvertently they may inject into the cavity where you can have a false negative study. So just to understand the lymphatic drainage. So usually the lymph nodes, it is draining into the obturator nodes, goes into the external iliac and then into the paraneotic. So this is just a representation image of a 62-year-old lady. So we have done the injection. The planar scan shows the successful visualization of the sentinel lymph node within 10 minutes of the injection. And SPECT-CT helps us to identify a single node in the right external iliac station. So going on to the endometrial malignancy, there are different injection techniques, but we follow the cervical route. You can also use the hysteroscopy or the transvaginal ultrasound guided injection techniques, or direct inoperative procedure can be undertaken by injecting into the anterior fundal. Injections can be given. So we are injecting at 3, 6, 9 and 12 o'clock positions. You can also use the indocyanine green or the blue dye along with the technetium sulfur colloid filtered or with an aneuploid to make the injection more obvious. So this is one such case. So we are giving the injections operatively. And the SPECT-CT shows us the visualization of a single node and the movement of the nodes further into the paraneotic stations. So vulvar cancer, very rare, but it's a malignancy of the elderly. Most common type is the squamous cell, but although it's a rare type of tumor, the involvement of lymph nodes is quite high, and the overall survival also is high in patients with the lymph nodes. And the most important procedure in patients who are node positive is inguinal lymphadenectomy, which has to be undertaken in all patients where the sentinel lymph node is positive on the biopsy. So just to understand the lymphatic spread in vulval cancers, we need to understand that these are superficial tumors. Sometimes the lesions may be involving the skin, so direct tumor infiltration is possible. So adequate visualization of the tumor, palpation, understanding where you are going to inject is very, very important. See if the tumor has a necrotic center. Avoid injecting into the necrotic center because it can lead to a false negative study. Midline tumors, clitoral tumors, you need to see both sides of the inguinal lymph nodal stations and pelvic lymph nodal stations because contralateral nodal involvement can be a high possibility. Imaging is the same, and you can do both the planar and the SPECT-CT study. A representative image, you can see that this is the contamination. So SPECT-CT clearly shows that the inguinal node on the right side is involved. That's the sentinel node. So moving on to the vaginal cancers. So this is again a rare cancer, not many studies, and usually it's a peritumoral injection followed by a static SPECT-CT imaging. So the protocols also depend. Like if your surgeon wants to operate on the next day early morning, we can do the imaging on the previous day. Maybe at the fag end of the day, you can do the imaging and do the probing on the next day. So CA ovary, very rare, very heterogeneous tumors. You can have a lot of mucinous component. So here, it's always an intraoperative injection, and there are no studies which recommend at what time the probing has to be done. But from literature, I found 3 different routes of injections. One is near the hilum of the ovary. The next is along both the ovary ligaments, and the last is the injection into the cortex. So they have shown that the injection at the hilum of the ovary and the ovary ligaments have a good detection rate. So we have gone through the procedure and various advantages. We also need to understand what can be the limitations in gynae malignancies for sentinel lymph node imaging and biopsy. So you must be very careful where the injection has been given because the injection is being given by the gynecologist. So it's always ideal for the learning curve that we as nuclear medicine physicians are there by their side to overcheck the site of injection and to see that there's no spill or contamination happening. The nodes can be masked if they have injected a lot of activity at one site instead of giving it at 3 or 4 sites. And if the patient has undergone multiple surgeries, the fibrosis can limit the visualization of a sentinel lymph node. So to conclude, sentinel lymph node imaging and guiding malignancies is feasible, practical, it's very good, very useful, because it can obviate the need for unnecessary lymphadenectomies, especially in early malignancies, not negative. But as nuclear medicine doctors, we need to understand the scheduling, the dosage, the technique to be standardized, because it's basically an individualized technique management. If the tumor is small, you can limit to 1 injection. If it is a large necrotic tumor, it needs to be slightly more. And now we are threatened by the availability of indocyanine green, especially in robotic sentinel with the robotic arm surgeries. So it's really very good, excellent. So we need to do our stand to get the sentinel lymph node imaging going. So this is one of our presentations in publications in NMC, where we have studied the uptake according to the KI index and histology of patients. The time permits, I'd like to run a small video on the endometrial malignancies, which was done in our center.
So,
Injections, 0.4 mercury in an insulin serum, filtered sulfur colloid, being injected along the cervical lip at 4 quadrants. Our department is just next to the labor room. Just need 5 minutes for the patient to be shifted back. But the patient has to be properly padded to start the SPECT CT or patient being positioned on the gamma camera table. Then we have a hand-held battery operated gamma probe, which needs to be sterile draped. So we have been doing gynae sentinel lymph node malignancy, sentinel lymph node since 2008. So our surgeons are quite well aware of the techniques and the procedure. Being checked for counts. It's also alarm along with it. And XP counting of the sentinel is usually recommended to see for the completeness of the surgery. So the counts usually just take digital counts in the background. This is a very so
thank you. Yeah, we'll have questions in the end of this, please.
Thank you, Dr. Verma. I would request to share the clinician's perspective. Batra. She's the senior consultant, ranking oncology at Max Cancer Institute, Saket.
Very good afternoon, everyone. Thank you, Dr. Jaspriya, and thank you, Dr. Swagat, for the kind invitation. An excellent work shown by Dr. Padma on the pioneering work she's done with the sentinel lymph node in gynae malignancies. So I'm just going to talk about the practical aspects. So lymph node metastasis is one of the major prognostic factors for recurrence death in gynecological malignancies. So the concept, we've had enough discussion on that. And the rationale is to have a precise risk stratification, that is identifying which are, after we've identified the patients at low risk who may be spared the extensive lymphadenectomy. You minimize the morbidity by reducing the risk of lymphedema. Then accurate nodal assessment is done by enhancing the sensitivity of lymph node evaluation. And we can have a tailored treatment, ensuring that patients receive appropriate treatment based on their nodal status. So in medicine, as in life, answers are not easy. The debate over sentinel lymph node, it reminds us of the complex decisions we clinicians must make, weighing the benefits of innovation against the risks of tradition. So certain clinical considerations that we need to make are patient selection. It is appropriate for any program to be successful to choose the right patient. So low risk, early stage patients are ideal candidates to begin with. And understanding that there is false negative rates despite everything. Then the expertise of the surgeon and the pathologist. So the procedure could be vital stains or radioactive isotopes. The dyes most commonly used are ICG and technetium 99. So talking about sentinel lymph node in endometrial cancer, where it is very much established as the standard of care. So sentinel lymph node in CA endometrium, mostly it's quite attractive because the patients are obese, and lymphadenectomy, the entire lymphadenectomy, it attracts technical difficulty, vascular injury, and morbidity associated with lymphedema. So there are these practical guidelines, the SGO clinical practice statement, which says that it is absolutely wise to do sentinel lymph node. It is systematically and survival advantage of doing complete lymph. So sentinel lymph node mapping and ultra staging, they have been proposed as a method to potentially reduce surgical staging morbidity while maintaining prognostic. So the logic of sentinel mapping lies in targeting the nodes that are most likely going to harbor the disease. And the goal of the sampling is to obtain a representative biopsy. So sentinel lymph node assessment in endometrial cancer started way back in 2008, and we have this is the systematic review and analysis which that sentinel lymph node mapping is feasible and accurately predicts the nodal status in cancer. And the data, it suggests and favors the use of cervical injection like ICG, and it is an alternative standard of care for staging. So the very famous FIRES trial, which was a multi-sector prospective cohort study. This was published in the Lancet, in which the ICG type was used with a high degree of diagnostic accuracy, and it can safely replace lymphadenectomy in staging of endometrial cancer. However, we need to understand that there is a 3% risk that sentinel lymph node biopsy will not identify mets with node positive disease, but it has the potential to expose fewer patients to the morbidity of complete lymphedema. So this is how typically the drainage occurs. External iliac region drains about 30%. Internal iliac and obturator 59%, common iliac 8%, and para-aortic 3%. So the mapping techniques, they could either be two-sided, two-quadrant, or it could even be four-quadrant. And the idea is to use 4 ml of the dye, 1 to 3 mm superficial injection, and D 1 to 2 centimeter, 1 ml each. So this is basically fluorescent SLN mapping, which is most commonly used in. And then after we have harbored the node, he lies in ultra staging. So all the nodes that have come out to be grossly negative in the histopathological examination, they are if negative, 2 adjacent 5 microgram sections are cut, 50 microgram apart, and at each level, one side is stained with HLE and the other with cytokeratin for a total of 4 slides per block. And with this method of ultra staging, an additional 3 to 4% micromets can be detected. So this is how the equatorial plane of slicing is done. It could either be red lobe slicing or longitudinal slicing. So this is basically the methods of cervical injection and the common locations. And the principle of evaluation and surgical staging when sentinel lymph node mapping is used is to start with peritoneal and serosal evaluation, and then after opening the retroperitoneal spaces, excise all the mapped sentinel lymph nodes with ultra staging, and any suspicious or enlarged lymph nodes, they have to be removed regardless of mapping. And if there is no mapping on a hemipelvis, then a site-specific complete lymphadenectomy is to be made. And the decision to do para-aortic extended lymph node dissection is to be decided by the attending. So in our institute, we did this study, which was a prospective study, where the role of sentinel lymph node biopsy in low risk and intermediate risk early stage endometrial cancers was assessed. And it was a dual dye technique that we used with dual dye and dual site. So in this, either methylene blue or ICG, one of them was used. And for validation purposes, radio tracer dye was also used, technetium 99. So the site that was selected was cervix and subserosal uterus. And this was to be done in low risk, and high risk ones, complete node dissection was done. We published this in the Indian Journal of Gynecological Cancers. And the study, it suggests that sentinel lymph node biopsy is an adequate technique to evaluate lymph node status in early stage disease. With more than 95% sensitivity and 100% false negative rate, 100% accuracy with no false negatives. And the morbidity of the procedure was good, and it was desirable in all women with low and intermediate risk stage. So the other advantage of sentinel lymph node is that unexpected locations can be treated. 7.9% of sentinel lymph nodes were detected in areas not routinely harvested, which is a major advantage. And even in the FIRES trial, 17% of sentinel lymph nodes were found in aberrant locations, which could be internal iliac vein, parametrial, or receiver areas. With improved detection rate of metastasis, which attributes to the application of ultra staging pathology, can help find previously neglected metastasis and the identification of lymph nodes outside of the routine area. So as revealed by the FIRES studies, 17% of lymph node positive patients were found in non-traditional sites. So the improvement of detection rate of metastatic lesions may mitigate the false negative consequences of sentinel lymph. These are some unusual sentinel. Then 8% to the right hemigastric, then the para-aortic regions and the receiver. So according to the latest guidelines, there was an intention decided that even for high risk cancer endometrium, one can do or consider sentinel lymph node. But according to the latest Pan-Asian ESMO guidelines for clinical practice, which was published and practice in our institute as well, in the high-risk histologies, that is stage 1 serous and carcinosarcomas, we do full surgical staging, including pelvic and paralytic. This is just a short video to show how invasion, ideal candidate for sentinel. As the lesion size increases, the number of positive nodes being harder. The issue is whether you resect 1 or 2 sentinel lymph nodes or to do a complete resection. And the chances of lymphedema are as high as about 7%. First attempt in gynecology was started in 1979 with a lesion 1 centimeter or less with less than 5 stromal invasion. So now we have enough studies, the GOG study of the superficial groin dissection versus dissection and the attribution was to be. These are other studies basically that suggest that false negative rate is to the tune of 0.3%. So it's very important in vulvar cancer. But the issue is not just about morbidity, which is predominantly lymphedema. It is also about the risk. The question that needs to be asked is also what risk of death is there in a patient who is properly informed, is prepared to take, because groin recurrences are bad, in order to avoid this lymphedema. There have been various studies that compare, this one was a comparison of quality of life between vulvar cancer patients after sentinel lymph node procedure only versus inguinofemoral lymphadenectomy. This study in particular did not support the original idea that a decrease in long-term morbidity also translates into an improved overall quality. And the surviving cancer patients might coincide with attitudinal changes. Cancer patients report that the cancer experience changed them in many ways, that it enriched them, deepened the compassion they felt for others, and for the environment in future. But there are issues that they still face. That, the axillary versus the vulvar, a lot of these phenomena are there. Axillary node recurrence, patients with breast cancer still receive a lot of adjuvant therapy, the form of hormone or chemotherapy. Whereas in vulvar cancers, with their being patients really need to be told this specifically in vulvar cancers. Majorly in cervical cancer, it is done in stages 1A1 to 1B1, and the sensitivity has been reported to about 90% with the identification of nodal metastasis by positive sentinel. a good negative predictive value as well. There have been various meta-analyses which have said that in these stages, 1A1 to 1B1, that the combination of tracer with immunohistochemistry is associated with a higher sentinel detection rate. So to conclude, in endometrium, it is an established claim, oncologically safe, vulva, number of patients who experience recurrence in the operated groin is of concern and may be attributed to the decision to leave femoral nodes intact. CS cervix, it may be considered in patients with low risk tumors but tumor sizes smaller than 2 small cell subtypes. Thank you.
And I have a couple of comments or questions. Any experience with ovarian cancer? Because that's another area with extensive nodal section, and I think Dr. Padma raised a point which I think is worth.
No conclusive evidence, but people are doing it early stage.
Ovarian? Early stage.
To localize. That scenario,
We haven't done it. ICT experience has been excellent. In fact, we have data for 50 patients now. And the majority are ICT.
deep-seated nodes with if you have a very deep-seated nodes, more than 1 centimeter deep, the planes, are you able to trace them with ICG? You have any issue with tracing deep-seated nodes with ICG?
The method to do it is to open the rectoperitoneal spaces to begin with, and after you've identified the IP ligament, then you've identified the obliterated to make the planes, and you see the entire pelvic node, and then you put on the 5 nodes. Very beautifully, we see tracks. Saw that video, the nodes which just shine like that.
Sometimes we find it at very unusual places.
The audiences will throw us out, so better we leave the hall immediately. But before that, I really want to thank you from the bottom of our heart for having us here. Thank you very much. Thank you, sir.
Thank you, Dr. Kadigan. Thank you so much, chairpersons. Move on to our next talk. Best Dr. Stephen Fanti to keep us on stage. He is the Professor of Diagnostic Imaging at University of Bologna, Italy. Essentials of writing a manuscript for a high impact journal.
Great pleasure to be here. Thanks for the invitation. Thank you for inviting me here. Okay, here are my disclosure. I guess that I'm here today essentially to briefly discuss the younger, which are the tricks for writing a successful manuscript. I'm associate editor of the JNM of the European journals. And I will start with a very simple question. Why writing a manuscript? That's the very first thing you have to consider. It's not strictly mandatory. It's not necessary. There are so many other things in life rather than spending time writing a manuscript. But the first reason is about science. The scientific method is supposed to start yourself asking a question, then making hypotheses, then making studies, and so on. And it ends with communication of the results. So, if there are either be talking to a colleague, something I do recommend, making presentation at some congress, writing a book, and the list is in growing importance. So the most important is finally writing a manuscript to be submitted to a peer-reviewed journal. So the first reason is that you want to progress the science, which is very good. We're very much motivated and devoted to our mission of being a doctor is a mission. But it's not only about this mission, it's also about career. Because I would say, unfortunately, the pressure towards publication has become more and more important in recent years. Because it's no longer enough to be educated, experienced, skilled, fantastic at your work, and so on. You also write some publication because I'm not happy to use the term competition, but sometimes you have to prove that you are good at doing great things also for the science. And several measures have been invented. One of the most known is the H index. I get the impression everybody knows that they recently invented just to properly measure. When I was young, there was no such point. It was just about the number of papers. Need to progress your career, which is quite acceptable. And I'll have some examples. Now, this is from Michael Hoffman. I guess you all know him. He's a very known guy from Australia, Peter Mac. And when he was reasonably young, some 5 years ago, he published this paper on the Lancet Oncology. Lancet Oncology is a very good journal. And what he did a very simple paper, but very, useful for his career and useful to bring attention to the scientific world to a very important topic, which is lutetium PSMA. It's clear that it was successful on both point of view. I mean, for either the career and the communication of science. So the point is now how writing a manuscript. Once that you have decided that it's worth spending your time with that. So how you write it? Well, first of all, you have to decide which sort of manuscript you're going to write. And for every measurement of bibliography, there are papers that count and papers that doesn't count. So I strongly suggest you to keep this list, which start from top left in order of importance. So whatever is in your right, it's barely countable. And in the left, it goes down to up. So essentially, you should search to write an original research article, which is the most valuable manuscript. So you are describing the project that you have been running. So there is a hierarchy that you have to take into account. It's very unlikely that with a case report, well, we can come back. There are also case reports that can be published. But it's absolutely unlikely that with a case report you can go on a good journal. So take your decision, and as said, you take this evaluation with the hierarchy. You should probably choose original research. And then it comes to two factors, essentially. The quality of the study, so the material that you have in your hands, and the quality of the writing. And again, I'm going to show you some examples. But the very most important point is the quality of the study. So what you're going to write about. This is an example by nice colleagues, and you see it ended up to be published in Urology Oncology, which is quite a decent journal, but nothing else. Why? The group was very strong. A group of very well-known scientists in the field of nuclear medicine. The topic was apparently hot, actinium PSMA. So what was the point? Do not get into the Lancet Oncology, just like Michael Hoffman did. It's an observational monocentric study. That's the point. If you are running retrospective studies in one only center, you will never get an unmated. If you have 13 patients, you will never get into a picture. So the very easy suggestion is, if you really want to make it big, you have to consider multicentric, prospective, if possible randomized, but not strictly necessarily randomized. But of course, the quality of the trial is what really makes it. And that's an easy example that everybody knows. You know, that's the Vision trial that was published a couple of years ago on the New England Journal of Medicine. New England, I mean, impact factor 160, one of the very top in the world. And what was that? It was simply a multicentric prospective trial with some 800 patients. Now you may question, okay, that was a sponsored trial. There was money behind it. It's easy to make that when someone is paying the bill. Okay? But not strictly necessary, because for example, the Australians are running a great trial, like the therapy, which was funded by a foundation, which is Movember. So my suggestion is, you are relatively new in this field. You can consider to run, national multicentric with some sort of funds grant from the national healthcare system and so on. This may lead you to great journals. And this is the peer review process. Probably you all know. Take into account that as editor, I frequently make test rejection. So if you are submitting your paper to a very good journal, expect that will be rejected immediately. Just because, the quality of the material is not sufficient. So the first point is, have a great studies. Consider to have the support of a methodologist, whatever you want, but the study design should be good. And here is another example, and it's again from my friend Michael Hoffman. He went to the Lancet, and they did it, and we can apply some characteristic of this trial. Again, randomized trial, multicentric, phase 2, not phase 3, so not so many patients. What is it all about? It's all about how clear is the study. The study design is fantastic. You have just 2 arms, randomized, two tissue based. It was absolutely new. It was nothing like that. Yet, we don't have another publication like that. And it was very short. The Lancet is not accepting 10 pages. Be very, very short, very clear. Just few images, okay, like this. And by the way, the objective of the trial were not absolutely outstanding. It was PFS, not overall survival. So you don't really need to be the best trial. It's well written, with nice, don't submit the same paper to different journals, don't do self-plagiarism, don't manipulate the data, don't make, the so-called salami, that's to say, slicing your trial and try to sell it to 10 different journals and so on. These are very, very easy. There is some ethic that you have to respect. But again, this rule can be found everywhere. It's just to remind all of you, there are strictly rules that you have to respect, especially choose a target journal of your manuscript. I mean, you should be critical. You take a look. If you don't have great material, don't try to sell it to Lancet. Just a waste of time. There's nothing publishing on organic communication. If you have a good material, give yourself time to improve. Don't get is always the best way to learn. Never forget that. And respect the ethical rule. Again, be trivial, never try to cheat, simply because sooner or later you will be stronger. Not good for you, for the institution, and for the scientific. And again, many thanks to all of you for our attention and for the invitation. Pleasure.
Sir, for your valuable insights. I would like to welcome on stage Dr. Dinesh Darkar for the next speaker. The Director, Sarvodaya Cancer Institute, Sarvodaya Hospital, Faridabad. So the stage is open.
Good afternoon, everybody. I think you have just heard a beautiful talk on why publication is important and what should be the focus of publication. So let me tell you, publication is extremely important, especially a lot of you are young people growing in your field. And your growth will be determined presently by one most important factor: how many publications, where publications, and what they actually have. So case report, I would just like to let you know that case report is a publication, but is not a publication. So please go beyond case reports. I know all residents, their basic job is case reports. When you scrutinize PubMed, you'll find hundreds of case reports. It's good. It's good to initiate with the case. It's really good because you are getting used to something. So publication is important. So what I want to bring to you today is how can you do a faster publication or a faster research or a faster writing. So I would be actually bringing to you some important, I actually call them video games. And I assure you, if you listen to me carefully, after finishing this presentation, all of you will be on Google, all of you will be seeing what I'm teaching you, and I'm sure if you are really interested in writing and publication, rest of your life, you will be hooked to this presentation. That's what I'm bringing to you. It's really very interesting. Okay, so whenever you write I'm sure you read all the articles. These are the main 5 chapters of the article. So introduction, material methods, results, discussion, and references. So you are focused on these 5 topics whenever you want to write something. So this is standard, irrespective of the publication you want to make. What it actually means. So if you want to write an introduction, or if you want to write a discussion or a reference, what you have to do the data mining. Unless you do data mining, you will not be able to write these 3 chapters. Material method is yours. You know how to write it, what we have done. Results also you know what you have done. These two things are very well known to you, but unfortunately you are not still able to finish. You are still not able to finish the publication because your basic issue lies with data mining. You are not able to find the appropriate journal, the article, what to code, where to code, how to put it in a sequence. So I just want to tell you what comes to your help today is these are the few AI applications, artificial intelligence applications, which help you in writing a publication. There are only few I have listed here. There are many, but these are the ones I like. These are the ones I use. Not all of them. You have to really get an experience of them. So this is a very, very important slide for you, and this is what I'll be explaining why few of them are important. These three, I believe, are extremely important to initiate. The research lab in Mendeley and Pepperport. Some of them would use Zotero in place of Mendeley, so it's up to you what you use. But I'm sure these are the ones, if you know, you can initiate your writing. You know about chatbots, you know about ChatGPT. So please, they are good, but they are not good for research writing. They are good for general mining. It's better if you want doing professional writing, be away from them and use the specialized ones rather than the general ones, the Bing or ChatGPT-4 or something like that. This is a slide I've taken from Mushtaq Bilal, who is my mentor, who taught me how to use this. And this is an extremely important slide for you. What it says, outsource your labor to AI, not your thinking. So use AI to work for you, but thoughts should be yours. Thinking process has to belong to you. Don't think that AI will give you all the solutions. Don't take the results. In fact, there is an AI, if you put some, like ChatGPT, if you put a question mark there or ask the ChatGPT to give you references, believe it, it will give you references which do not exist. So please be careful. Use AI as your research assistant. He is your helper, he is your supporter, he is not your supervisor. You can use it to create a structure, not a content. Remember this. And don't over rely on AI. Do not forget to use your common sense. This is extremely important because what is happening today is we just use AI, whatever is written, you just take it. Don't do that. Please. AI is important. I'll show you the speed. It will give you a phenomenal speed, but still use your common sense when you are finishing the presentation. So one of the very important AIs which you should know is Elicit. Elicit is an important tool. So I'll just give you 1 second. So this is life. So this is how this thing comes up. This is just one of the AIs which you can use. It has got 3 options called find the papers, extend data, and list of concepts. So for example, we want to find some paper related to some topic. So let's go next. So let's say find papers. Ask a research question. So I want to ask research questions. What are the indications So indications for PET CT scan in lung cancer. Let's believe that I want to write this topic in this site. So I write, can you see this? So indication for PET CT, sorry. Indication for PET CT scan in lung cancer. It's actually fast, but okay. So what you have got? So you already have. I don't know whether you are able to see it or not, but if you really see this, it exactly gives you some data. So it's summary of the 4 papers, and it says these papers collectively suggest that PET CT imaging is valuable in the evaluation and management of lung cancers. There is a reference. Highlights the ability of PET CT to provide precision, disease staging, and useful data for characterizing pulmonary nodule. There is a reference. So, in just 1 minute, you got something to start with. So, this is how this can help you. So, we have already found out some papers. So, there is a paper, there is a reference, and there is an abstract summary, all at one place. It's not just Google. Scan in lung cancer. So now we just want to find out using same AI. So as I said, there are multiple of them. There are few which you should get used to one by one. Don't work on every AI together. And that would really make you understand the app better and increase your speed. So now, if you really need this, you see this? Already all concepts are there. Where PET CT scan helps in lung cancer. So it's detection of recurrence, identifying a new primary, early diagnosis, staging of lung cancer diagnosis. So you already have the concept where the AI would help. And there is a reference for every concept. So when you want to go to the details, you can actually go to these original articles and read. So AI will help you conceptualize your topic of research very, very fast. You can scroll it. So these are all the concepts for evaluation of mediastinal lymph node, examination of extrathoracic abnormality, detection of disease recurrence. So these are all the concepts where PET CT scan is indicated in lung cancer. So you already have enough of information to proceed. If you have this enough of information, you can actually start writing an introduction, you can start writing the discussion, which are 2 important topics where you get stuck when you are writing an article. So this would really help you. And as I said, it's like a video game. Keep playing it. The more you play, the more you will enjoy it. If you wait, you will actually start getting the source. So predicting lymph node downstaging, it is already giving you a reference from where this has been taken and what this article reads. The source says predictive value for lymph node downstaging become in acceptable ranges and PET response in primary tumor could be clearly linked to pathologic response. So it is already giving you a concept, it's already giving you a reference, and already giving you from where the concept has come. In other AI, you can actually put them, you can filter them year-wise. So maybe you want a concept of 2023 only. You don't want to need you don't need a concept of 2002 because naturally that would have been different. So you can actually filter these and bring them to the So I done the same exercise before because I really wanted you to show how it means. And it will, when you go to the papers, you will actually get everything, concept and the reference. So let's go to another layer. So one AI you should remember is evidence-based or elicit.org. So that's a good AI which you can use. This is another AI which gives you a consensus. This is a beautiful AI which actually summarizes the points extremely well. So I'll not go to the internet because I have no time left. That's great. So I have done this. I have again put the same query indication of PET-CT in lung cancer. And it will again give you all the references with their concepts. So, if you see answer on this, if you can really see what is written here, it actually enumerates all the indications. It's already there. You don't have to do anything. It already says it's in staging how it helps, in assessment of operability how it helps, in treatment evaluation, in follow-up surveillance, differential between benign and malignant, so on. So there are 7 concepts, 7 indications where PET-CT can be used. Already done by one AI in 1 minute. So you now have an information from where you can start going. So unfortunately my time is finishing. I would like to stop, but if somebody is interested, and if you don't want to go for the lunch, I can continue. So it's up to you. Yes, please. Continue. Okay, thank you very much. So this is, so let's get to the most important AI which I actually love. So this I will show you live. This is a very, very important tool called Research Rabbit app. ResearchRabbitApp.com. Extremely important if you want to review the literature. Just put the topic, it will give you a lot of information, it will give you a lot of data, and you can actually study all the articles. You can choose depending on the year you want. So for example, so on the left top, you can create your collection. So if you want to collect, for example, PET-CT indication, you can create that group. So I created that collection called indication for PET-CT. So if I click on this, it pops up. In this box, you can create your own collection. So I wrote here indications for PET-CT and I collected it. So this is the one I collected. Once you have written it there, then you click on it and the new window pops up. So then here, this is one of the articles. If I want to really study articles, once you click this article, you can write whatever. If you know some article, you can write an article. But if you know no article, you can write. So for example, I write indications for PET-CT scan in lung cancer. It's an extremely important tool. So what it has done is, unfortunately, it's really very bad projection, but it will give you all the papers. So I just actually gives you all the papers. What is best part of this is, once you have done this, you see that there is something called add collection. So what you do is, you read this paper. If you like it and you want to retain it, you put it to your collection. If you don't want it, you just forget about it. So for example, I like this paper, so I write add to collection. It will go to my collection. Then I can scroll. There are many papers like this. So a role of non-FDG, trace in lung cancer, PET CT scan, thermorelation, semi-quantitative. Let's put 2 3 here. I'm not wasting time but I just write what I want. Once I've done this, I can close this. All these articles will present here. They have come here. And what is best part is there is a custom upstairs. So if I say recency, it will tell me. So now it is by year. So 2022 is on the top, 20. So I can actually select because sometimes we are interested in using only recent article. So you can choose 1 year, 2 year, 3 year, 5 year, and read only those and not read the other ones. So, and once you have got this article, then you can choose which you like best. For example, let us believe that I like this one. So, editorial comment, evolving indications. Unfortunately, it showed that there is no PDF. So, there is no bigger article available for this. So, I will not be able to get an abstract and a full paper, most probably a paid paper or something. But if it is available, it will show you that. See, but at the same time, what it is showing additionally is here, if you see this column, it is actually showing you how many the authors have done and what are the another suggested articles. So you can actually find all articles related to this and go through them. So that is the base part of this. For example, the author who wrote this article, this author, if I click this author, it will show where is his published work. And what references he has used. So it will tell you what are the other references of the same person or the references he has used. You can go to this reference and you get another article. Again, you can add this article to your list. And ultimately, you will build a list of publications which you are interested in. You can delete the other ones. And this list from here can be transferred to Zotero or Mendeley. So Zotero or Mendeley are the two important publications which will build your reference list. So from here, you can go to the reference. So you got an article already, you got an abstract already, and you got a reference list already. Lot of your work is done. So this is researchrabbitapp.com. There are so many articles, so many apps like this. There are another two very important ones, which maybe I will talk to you sometime next time. Again, there's a bell, so I'll have to stop. So this is what is important if you really want to publish. And if you are in science, it's simple, publish or perish. There's nothing in between. So please publish. One more AI which you are supposed to use and know. The most important for all of you, even in routine day work, it is known as paper pal. PAPERPAL. Paper pal. Paper pal is used in Word. So whenever you are using Microsoft Office Word, there is an addition called paper pal. It will go and sit there and from add-on. So you use a paper pal add-on, whatever you write. So you've written some one page of something, open the paper pal and it will check every line and tell you whether your English is correct, whether you have to change the word, whether you have to change the alphabet. And it's in Word. So it's your routine life. You can actually, even if you write a plain simple letter, you can use a paper pal to correct it. It's very easy. So please definitely try to use that app as well. I think that's all I wanted to tell you. I'm sure you must have enjoyed it, and I'm sure you would have loved it and you will continue to use it. I'm confident. Thank you very much. I'm a medical oncologist and director of oncology, transplant expert, and a physician. Nothing to do with software.
We'll quickly go for the lunch break and assemble back for the next sessions.